welcome all of you to this occasion, Bioethics in Action, highlighting work across the consortium. The Adventist Bioethics Consortium is a collaborative effort of all the Adventist health systems in North America, plus some other organizations, AdventHealth University in Florida, Andrews University in Michigan. And we've grown to be an international consortium now with Adventist Healthcare in Australia and our Health Sciences University in Peru. So it's a growing consortium that has as its intention sharing information that's useful across the various organizational lines. And I want to welcome all of you to this today and turn the time over immediately to the person who has organized this occasion, Dr. Grace Wee. Let me introduce Dr. Wee. She is the Associate Director of the Center for Christian Bioethics at Loma University. She's also the Director of our Clinical Ethics Service here for all of our hospital system that's connected with Loma University. As you can see, she's a assistant professor of pediatrics and works regularly in the hospital as a practicing pediatric intensivist. She also holds a Master's of Arts degree in bioethics from our university here at Loma Linda, a fact of which we have some, I think, justifiable pride. So Dr. Wee, the time is yours.
Thank you so much, Dr. Winslow. Welcome everybody to part 2 of our Bioethics in Action webinar series. I want to quickly highlight how to ask questions. We want to encourage dialogue, although I will admit that the time for dialogue will be short. But nevertheless, please ask a question, and all unanswered questions will be forwarded to the presenters for them to answer. Then we'll be posting the Q&A on the website. So to ask a question, just click on the chat button in the toolbar and type in your question. We have our graduate assistants who are monitoring that, and we'll be recording all of making sure that we capture all of the questions. And again, if we don't respond to your question, please do not despair. We're going to have the Q&A posted after the webinar is finished. Please allow a little bit of time for the Q&A to be posted, but we want to make sure, again, that we are encouraging dialogue. I think that we are going to be in for a real treat this webinar session. For those of you who attended our last webinar session, we had some very provocative and fantastic presentations, and I think you'll also be pleased with the presentations coming up. I'm going to keep the introductions really brief in order to turn the time over to our presenters, but first is Dr. Carr, Mark Carr. He's the Regional Director of Ethics in Alaska, that big, beautiful state that is quite cold, I bet, right now. He is also Associate Clinical Faculty of Family Medicine with University of Washington School of Medicine. So Dr. Carr, thank you so much for being able to present to us.
It is my pleasure to present. I'm sharing my screen now. And by way of beginning, I want to just float the reality, the idea that this is a series of initial ponderings on my part. I have been thinking along these lines for some time in the hope that I would at some point write a more substantive academic article about it. So I want to encourage you to push and probe and adjust my thinking as best we can do together here. So moral compromise in altruistic service to the public. For some reason, having a hard time. There it is. Okay. In the early days of Adventist healthcare, I'm going to move that part of the pictures. Adventist healthcare was the entering wedge, a complex blend of altruism for others, adding to church membership and preparing for the second coming. And one of the biggest issues we fought about in those days was what to feed our patients. It seems that those times have changed. How many of our healthcare executives and caregivers actually know anything about the entering wedge? If we were to use the phrase with them, would they know what we're talking about? And the idea of convincing patients to join the church and prepare for the second coming is an afterthought. Modern American healthcare is primarily a business explicitly designed to extract money from sick people. I know that sounds shocking, but when looked at particularly from the perspective of other developed countries, this statement is rather shocking. Now we treat customers rather than patients. Under federal and state licensing and accreditation, our customers have rights and expectations. And faith-based healthcare such as ours is different. Let's not kid ourselves. We are a different kind of healthcare, but we remain a business. And in fact, several faith-based healthcare structures, corporations, are doing better at this business than many for-profit companies. But it's an eleemosynary business. And I highlighted that because I want you to look it up. It's an odd word. It's attributed to Milton Friedman, who is the principal interpreter of Adam Smith for American capitalism. So again, the point is that we're a business, even if we're a different kind of business. Okay, moving along. The American public has evolved morally in ways that are often at odds with our prevailing ethos. Abortion remains legally available and should be offered in hospitals that serve the American public. Gender identity and transition therapies and procedures are clinically standardized and should be available. Assistance in dying is legal in several states, and customers expect it to be available in our hospitals. All right, so my essential claim about altruism, if it is true that Christ sacrificed himself for others, and if it is true that Christ's disciples ought to model themselves after him, then it seems true to me. Now, I did not ever take a class in logic, so if you did, please forgive me for failing the logic test here. This is rather simple-minded, but it seems true to me that we ought to be altruistic in our efforts to extend Christ's healing ministry. So the definition of altruism, placing the needs of the other over your own needs, by definition. It's a fascinating field and it's worth looking into. Lots of debate about what altruism is. So in a ministry to the public, the needs of the public should supersede our own. In other words, an out-facing ministry of the church, the healthcare ministry, is not the same. It is fundamentally different than an inward-facing ministry for ourselves. And I think that's a really important part to keep in mind. This places us, that is faith-based healthcare ministry in America, in a moral quandary. We should offer legally allowable, medically standardized therapies to our customers, but we don't because of our needs. To protect our needs, my question is, should we invoke our conscience, our religious liberty, or both as a means of navigating this difficulty? So, within the literature on conscientious objection, in healthcare in particular, these apply to us individually. Conscience absolutism. Now, this one says that nothing can impose upon your personal moral convictions and force you to engage in an act which you consider morally illicit, regardless of what the public does or doesn't believe. So in the end, you either get out of the business or stand in this territory of conscious absolutism and prepare for the onslaught of those who will disagree with you and try to force you out. The compromise approach, which is the one I'm arguing we are solidly in, says that healthcare professionals are at least obligated to balance their interests in moral integrity with, in moral integrity with patients' health needs and interests. And that's a direct quote from this person, Mark Wickler, if I'm pronouncing it right. So in this category, you stay in the business and you manage self and conflicts with the public in a manner that insists upon compromise. And then the incompatibility thesis. In other words, there is no room for your personal moral convictions when they conflict with the practice standards of your profession and the public you serve. So in this case, you stay in the business and you adopt professional and societal standards and override your own differences if you have them. I remember talking with students in pharmacy at Loma Linda, particularly on this area, this topic, and it was ever and always a difficult one for those who intended to remain always morally pure in their mind by never dispensing an abortifacient, for instance. All right, moving right along. Conscience on a corporate level. So, do these three positions legitimately apply to us on a denominational or corporate level? What exactly then is conscience on a corporate level? Can a corporation have a conscience in the same way that an individual has a conscience? And does the church as a whole have a conscience? If yes, then who gets to determine the contents of that conscience? What lies inside the acceptable limits? Therapeutic abortion, palliative sedation, gender transition. If the church does not decide the confines of our Adventist conscience, how can healthcare that purports to be Adventist invoke our conscience in order to avoid offering services to the public of a certain sort? The New England Journal of Medicine recently published this article by Ian Wolfe and Thaddeus Pope, in which they write, institutional conscience-based objection differs materially from the more familiar concept of individual conscience-based objection. Limits on services available at hospitals that function within the confines of religious doctrine pose substantial risks for patient choice, patient safety, and the fundamental principle of autonomy. It's a very provocative article, and I would urge you to pick it up and take a look. In December of 2019, what about religious liberty to avoid altruism? In December 2019, the North American Division published a statement in response to the Fairness for All Act. I don't know much about all that, but I read carefully the statement from the NAD with that title, With Religious Freedom Under Threat. As the fabric of society shifts, and people often ask as an ethicist, well, how can ethics and morality change over time? Well, that's fairly obvious. Ideas about it change dramatically, and we can find that in the pages of Scripture itself. As the fabric of society shifts, so inevitably do the political and legal realms. Among other things, the North American Division supports the Fairness for All Act because it protects both religious institutions and people of faith from being forced to violate their conscience in the areas of sexual orientation and gender identity. Healthcare providers will not be required to provide and/or perform medical procedures that violate their beliefs. So, officially, the church is wanting to tell healthcare people, you don't have to do these things in your customer-based services to the public, because your religion should allow you the liberty to avoid doing those things. A similar statement came from the Catholic Health Association with regard to gender transition procedures. I could have pulled that up. I decided not to. It's not an uncommon position to take for faith-based healthcare. All right. Moving right along. Over 2 years ago, Adventist Health West and St. Joseph struck a joint operations agreement in the Northern California market. They called it Sacred Trust. The California Attorney General's office denied the application in 2019, and he said, the Attorney General concluded that the proposed transaction is not in the public interest. The AG had received comments from various consumer and patient right groups, expressing concern that the merger of the religiously affiliated health systems would further restrict access to certain types of health services, certain types that the state of California apparently felt was important that its citizenry have access to, such as reproductive services, gender transition services, and end-of-life care, especially given that many of the health facilities are located in rural areas where alternative healthcare options are scarce. Now, that's another really important thing to keep in mind. And being in Alaska, I see this every single day. Some of the metropolitan areas where some of you are calling in from do not have that situation, and that's to be taken into account. Nonetheless, the California AG, Attorney General, decided that the merger, or the joint operation agreement, more technically, shouldn't proceed. All right, so I have two recommendations and one, I think, good idea. Two recommendations. Number one, church theologians should work with the General Conference and Adventist Healthcare Corporations to identify how we can or cannot have a corporate conscience and what are its confines. We should create structures to delineate our compromise position. A good friend recently in conversation, whose initials are Alex Brian, used the term redemptive flexibility as a synonym for compromise. Current structures, or create structures to delineate our compromise position. What are its acceptable ethical parameters? We don't like compromise in our tradition, folks, but we should get over it, because compromise is essential to a community of believers, period. So, for example, within Catholic moral theology, principles of cooperation with evil determine licit or illicit, formal or material. I was involved in a recent analysis, and this analysis resulted in a determination, and I quote, licit, remote, mediate, material cooperation with evil. Now, each of those four categories has, as you might imagine, additional categories. And this is a tradition that has developed over almost 2,000 years. So what are the structures, if we were to create structures, that would allow us to navigate this turf? And that's what I'm suggesting we need to do. And finally, a good idea, create an Adventist Healthcare Association that expands beyond public policy. Bless you, Jerry Winslow, and the others involved for getting the Healthcare Association going to such a degree as it is. But it needs to do more. We need to bring our systems together, because the sooner we learn to play together, the more likely we are to be successful to continue the teaching and healing ministry of Jesus. Thank you.
Wow, thank you so much. Very, very provocative ideas. You touched on Roman Catholic theology, and if I am correct in understanding, you're holding it up as an example of a way that the Adventist Church can delineate out its corporate conscience. Would that be a good way of describing what you're suggesting?
Absolutely. The principles of cooperation, you can look them up. It's easily Googleable. In balance with other principles of collaboration, the idea of a common good, and protecting one's own integrity while partnering with others who have a different idea of what integrity is to them. So it's a way of navigating this compromise space to categorize things. Now, it's not always fun. It's messy. It attributes to others things like evil. And it's arrogant at times, but it is a way of navigating the space that we're trying to inhabit.
So who coordinates that for the Catholic Church?
Yeah, that's a little difficult to characterize. It depends an awful lot on who your local archbishop is and how he manages to interact with the healthcare corporations in that area. There are structures above local archbishops, but a little bit like our own conference presidents and unions and division system, the most common place of difference and rub, if you will, is the local archbishop. And there's this thing called the principle of subsidiarity, which means that the closer you are to the actual event at question, the more likely you are to be able to discern and put a good position on it to figure it out as closely as possible.
I'm really liking that there's a lot of local input into this discussion.
Yeah.
Fantastic. Very good. Well, thank you so much, Dr. Carr. I want to, again, encourage everybody who's on to submit your questions. We're going to move on to the next presentation, but again, we'll be collecting the questions for our presenters to answer. So just type it in a chat, and then our graduate assistants will collate and record all of your questions. Thank you again, Dr. Carr.
You bet.
Our next presenters are Carl Ricketts and Hendrik Hutagaol from right here at home at Loma Linda, well, at least home to me, Loma Linda University. Carl is the Director of Chaplain Services, and Hendrik is a chaplain with our hospital. I want to turn it over to them. Thank you, both of you, for presenting this morning.
Thank you so much, Grace.
Thank you for having us.
We're extremely delighted to be here, and I will begin by sharing our screen here. And it is a pleasure to see many of the faces that are familiar and some of the names that are familiar around the country and North America even. And I hope that you all can see our presentation set up. Want to thank you all for the invitation and the opportunity to share with the larger body of bioethics in this country. Today we'll be presenting on the ethics of spiritual care in the healthcare setting and beyond. And I'm Carl Ricketts Jr., serving as Director of Chaplain Services at Loma Linda University Health. And I also have my colleague with me,
Hendrik Hutagaol, chaplain at East Campus Hospital of Loma Linda University Medical Center. Thank you for joining us.
And today we want to begin. I'll have Chaplain Hendrik kick off.
So why spiritual care matters in hospital setting or in healthcare setting? It is known that in suffering, people often search for meaning. Viktor Frankl talks about that, and it promotes the development of therapeutic relationship, but also it improves people's spiritual well-being, performance, quality of spiritual life.
Studies also show that spiritual care is very important throughout the entire healing process. It contributes to a shorter hospital stay, improved pain management, improved motivation to complete the task of healing. And is also proven that spiritual care is valuable and positively received, even by patients not seeking spiritual care. And so, who is responsible for spiritual care? Well, Sister White talks about employing varied agencies. And you may say, well, isn't that spiritual care responsibility of the chaplain? Well, therapists, nurses, physicians, social workers, all can be a part of spiritual care. Actually, research has shown that spiritual care generalists can be created. They've been trained in how to have spiritual awareness and to look out for the spiritual needs of patients within their scope. This helps to create human interactions of compassion and empathy. Research shows that the more human interactions a patient can have while they're going through their length of stay can contribute to their well-being. It is greater than even the processes of care that are created, also even greater than the environment of care.
Well, spiritual care can be provided by all disciplines of the healthcare. There's a question of why spiritual care is best delivered by chaplains. Well, most parish-based clergy only minister to the members of their congregations, and their time is mostly dedicated to their parishioners. There are many religious organizations. If the hospital should employ them, that's going to be too much, too complicated on the HR and other processes. And there are many people today who are not part of any faith community. As a matter of fact, a recent study from Barna shows that more than 50% of Americans claim to have no church or religious affiliations. And the other thing is most parish clergy have very little knowledge about disease process or hospital protocols. And I recently interviewed about 18 clergy in the San Bernardino area for my dissertation. And I found out that 15 of them actually say that they're really uncomfortable, some of them to the point that are intimidated by the hospital protocol. The three that say they're okay, they have taken CPE units. So there you go. And therefore, a chaplain would be best at delivering spiritual care.
When it comes to end-of-life situations, research has shown that most parish-based clergy, while they have beliefs that are very similar to chaplains in the care of patients from an eschatological position, many parish-based clergy will often seek to extend life when the situation of the patient requires more acceptance of passing away. And so this is what is often, it creates a gap where they will pursue life-sustaining measures as opposed to accepting that life is near its completion. And so why is spiritual care best delivered by chaplains? Chaplains understand the layout of the medical institution, and they know how to provide timely visitation towards patients. Chaplains provide spiritual support to care recipients and hospital staff. According to the Association of Professional Chaplains, the standards of practice call for chaplains to care for patients, their family members, and also the employees of the organization, so that they can then also inspire spiritual care towards patients. Chaplains can give appropriate referrals to the interdisciplinary team members working in collaboration with them, and also to clergy of patients when the patient desires care from their own pastor. Chaplains conduct spiritual assessments, and we'll go into this a little bit later. Spiritual assessments are critical to the care of patients. And chaplains also work with the screening tools, working collaboratively with nurses so that they can engage patients at the point of admission on their spiritual care. You'll find that chaplains will participate in ethics consultation, bringing and highlighting the important faith element that is necessary for ethical treatment of our patients. And you'll also see in end-of-life situations, chaplains are trained. In end-of-life situations, you'll notice that a chaplain is trained to respect the religious and faith beliefs of individuals of diverse denominations, understanding that those who are Buddhists prefer a quiet place when it comes to death, understanding that those in Hinduism prefer to die at home, and also to make resolution with all of their relationships before death. And so it is significant to have someone who is aware of the diverse population of patients, especially when they're nearing death. So we want to take you on a patient's journey, from the point of admission to the length of stay to transition as well. Chaplain Hendrik, I'll have you take us at the point of admission.
When a patient is admitted to the hospital, this is what we developed about a year and a half ago. Carl and I talk about how do we assess, or how do we help nurses screen their patients of their spirituality. So the spiritual care has begun upon admission. We draw from 1 Corinthians 13:13, faith, hope, and love, and on screening the patients. The first one is their support system. Do you have loving support from people around you or close to you? And it is very straightforward, yes or no. And then this also refers to the APC Code of Ethics that we talk about the hope. And this is very important for us because if a person does not have hope, we really want to see this person immediately and explore why and how we could restore hope in this person. And then faith. Is faith important to you? If it does it influence your medical decision? If it doesn't, then we probably don't need to talk about faith with this individual, but we could talk always about their experience in the hospital, and this will not only we are observing their faith or no faith, but we are upholding their dignity, the right to have no faith or to have faith. Spiritual dimension of a person is an essential part of individual for health, as APC Code of Ethics 110.12 says, wholeness and meaning in life. APC Code of Ethics 130 and -42, also Joint Commission recommend referrals and consultation in IDT relationship screening. So with the hope, if a person say she or he has no hope, we are designing right now that answer will automatically trigger a consult if the person says no to hope.
So what we're looking at here is addressing, even at the entry point of a patient coming into the hospital, at the point of admission, we're looking at the patient's loving support system, we're looking at their outlook, and we're also looking at their faith and how it intersects and informs their medical decisions. So now looking at the length of stay, as we look at the length of stay, we've created a spiritual assessment tool. This spiritual assessment tool looks at a few areas. We wanted to embed the spiritual assessment tool within the electronic medical record so that we could facilitate conversation and collaboration, awareness of the IDT around the assessment of the patient spiritually. So we look at religious and spiritual attitudes of the patient. We look at their beliefs and their decision-making, the intersection of their beliefs with their decision-making pertaining to their health care. And life. And we're also looking at wholeness and purpose. Does the patient exhibit that meaning in their life? We look at religious and spiritual integrity. Do they have positive thoughts, emotions about God? And also patient and family support. And what does that look like? Do they have trusted spiritual leaders? Do they have family and friends? Our chaplain team came together to create this tool. And what we've discovered is that we have an opportunity to communicate the spiritual needs of the patient based on the assessment. Are the patient's spiritual needs, according to the chaplain's assessment, are they high, are they moderate, or are they low? And this then creates a conversation where we can continue beneficence towards the patients in our healthcare settings. Our Code of Ethics call for us to seek to represent the best interests of those whom we serve. Looking at the spiritual care plan, I'll hand it over to Chaplain Hendrik.
Now, upon assessment, we be able to determine their spiritual needs, whether it's just a prayer, a Bible, literature, or a sacrament that is directly from their own clergy. And we facilitate this. We do have a stack of literatures in our hospital. Some of them supplied by local churches, and some of them are our own. So we provide their needs. And then religious, spiritual, and interventions. Beside their needs, what do we need to help them with staying in the hospital? A lot of the times, patients are not confident enough to ask questions about their medical condition or intervention. So this is also that what we advocate for them, that they communicate with the care team about the process of care or treatment that they're receiving. And then the goal and progressions with this intervention, this all are documented, and so the other interdisciplinary team member could also see this goal and progression whenever the patients agree to talk with us and to express their needs. So we'll facilitate this for each and every patient that require or request the spiritual care.
And so the communication and collaboration, again, are highlighted in the spiritual care plan, where we can actually communicate, and every member of the healthcare team, spiritual care generalists and also spiritual care specialists, can participate in the plan of the patient's spiritual care. We recognize that paying attention to the metrics as the hospital system continuously moves, and I want to appreciate Dr. Carr's presentation, even on do organizations have conscience? And there's a theory even of conscious capitalism. But even as we move into healthcare, value is often needed, and big data is out there. And how do we utilize even big data to inform our decisions so that we can become more efficient in our delivery of care? And so to provide service best practice, as we seek to have efficiency, we look to standardize best practice in our organization. And so we must learn what we're doing. So we have created a spiritual care dashboard so that we are fully aware of how we're practicing service best practice goals. How are we executing on our 24-hour visitation of our consults? How are we doing in our timely visits? How long do we spend with our visits? How long does it take for us to respond to our patients? We know we can nail down the duration. How long does it take for the consult to come in and for us to respond to the patient? Not only that, but we look at benchmarking ourselves with other organizations when it comes to HCAHPS. We strive to be at the 75th percentile in terms of addressing a patient's spiritual need. And so we want to make sure that we are paying attention to these measures so that we can provide the most efficient care to our patients. Ultimately, we're talking about continuous quality improvement, which informs our decision-making and how we set up our delivery of care. Finally, we get to the point of transition. And Chaplain Hendrik, as we transition, take us home.
In transition, we, at the time of releasing from the hospital, I usually communicate with the nurses or the doctors in the IDT meeting who's going to be released today to home or to other facilities. And I try to see them as quickly as possible, offer them blessings and ask them if there's any other things they need. Some patients have expressed their desire to reconnect with local churches. And I have had the honor of facilitating that request. I gave them the number of the church that I saw fit, the descriptions, the religious background of the patient. And the patient, I encourage them to call the clergy or the church office themselves and to reconnect. And we continue to offer them to call us whenever they need something from us. And so this is a continuum of care that we always provide, even when they transition out of our hospitals.
And so we have an opportunity, and the presentation mentioned beyond. The beyond piece is the forging or the creation of a new relationship, the relationship between chaplain, the patient/parishioner, and the parish pastor. We have an opportunity with patient-driven interoperability to literally give patients the ability to communicate about their spiritual needs from the chaplain to their pastor. Could you imagine a future where patients can use their applications, where they could share their location in the hospital with their pastor, where the spiritual needs assessment that a chaplain would give, that the feedback that the patient gets, that they could bring that back to their faith community as they transition out of the hospital, we have an opportunity with the move of healthcare going to the patient's use of their electronic medical record information to allow for spiritual connectivity between the chaplain services department and the parish-based minister. And I think patients utilizing and owning their own spiritual information can be a great tool for the continuum of care in spiritual delivery. And so we know that we have a great opportunity in that, and we seek to create partnerships in that realm. We want to say thank you for your time, and may God bless you as we all serve to ethically care for our patients, meeting their spiritual needs.
Thank you.
Thank you so much, Carl and Hendrik, for presenting that. I love this vision of making sure that we bring chaplaincy into the electronic medical record age and era. And I love that what I'm hearing, and building bridges across to different community churches and community ministers. That is fantastic. We have a few questions that just for the sake of time, we're going to go on to the next presentation, but I want to encourage those of you that are on, do not despair if we don't get to your questions. We will be forwarding questions to all of our presenters, and they will be able to answer them, and the Q&A will be going on the website. So again, thank you so much, Carl and Hendrik, for that wonderful presentation.
Thank you.
Our last presenters for this hour are Dr. Russ Butler and Craig Gillen from AdventHealth University. And I think you will find this presentation very interesting and informative. We just heard a little bit about how we are bringing spiritual care into the electronic medical record, and I think this is the next move forward in terms of information and big data in the medical show, or into the medical system. So I'm going to stop my screen share, and Dr. Butler and Craig, please take it away.
Thank you all, and really appreciate those two talks. That's incredible, thought-provoking, absolutely wonderful. I appreciate Dr. Wee and Winslow for putting this together, and I think that we have now the screen share. I would like to say, though, right at the outset, we know that healthcare is a complex and very complicated business. And I see administrators and I see the practitioners in church every Sabbath, and they're under a lot of stress. One mistake could be a death. Another mistake could be hundreds of millions of dollars in losses. And so I often hear some rash, finger pointing, and I think that we need to be careful with that. But I just want to say that I know there's a lot of pressure, and we know the complexity of it. And thank you for those talks. It's so thought-provoking. We use, you're looking at ARC Pro 2.6. This is from a company, Esri, which is in Redlands, California. And so we have an educational license. We do this. I'd like to thank Dr. Esti Garrity. She is the chief medical officer for Esri, and she's helped a lot. There's a lot of the other Esri personnel. Thank you, Dr. Stan Tobias. He said, why don't you submit an abstract? And I said, okay. He's actually a colleague. Thank you, Stan. And we'd like to thank the AHU, our university administration, for supporting the Center for Population Health. Now, you know that there's just so much information out there, and really to set the stage, we know that the healthcare in the United States is about a $3 trillion a year business. We spend about $9,000 per person, and what is the Medicaid Medicare budget? About $900 billion. Yet, we're at the bottom of the heap in terms of health wellness measures as compared to other industrialized nations, and we spend a lot more. And so we wonder about that, and so we're going to be discussing certain things. Now, we only have the ability to show you a surface of what we can do. And so we're going to focus on a couple of things. Now, Dr. Brenner, he had a healthcare practice, a primary care practice in Camden, New Jersey. About 2012, he went out of business. Now, he wanted to study that because his primary care went out of business, but hospitals in the area were getting larger. And so as he studied this, he found out that about 10 to 20% of the patients were costing about 80 to 90% of the total healthcare dollars. Well, the other thing that he discovered is that they were not randomly distributed through space. They were clustered. They formed hotspots. And there you see the hotspots. Now, these hotspots are worth for me and other colleagues. You know, we learned in geography that Tobler's first law of geography: closer things are more closely related to one another than more distant things. So we now know that a host of human health factors and pathologies are clustered. And so what we have is this. Now, here you're going to see what we're going to be looking at today. For our example, we're going to be looking at chronic diseases, and we're going to use a proxy of it, hypertension data. Chronic burden diseases, you know, it's a global problem. We think that's about 130 to 150 million Americans suffer from chronic diseases. We think that the estimate is about 2 million people will die from chronic diseases this year. We're at about 240,000 deaths from COVID this year, which is a terrible figure, don't get me wrong, but about 10 times that many will die this year from chronic diseases. And we also know that there are certain factors within chronic diseases, from childhood trauma to food availability. Now, food availability isn't just lack of calories. We're talking between a 7-Eleven and a Trader Joe's. Water quality issues. We published a paper out of the lab about the problems of drinking water in a local neighborhood, and also access to healthcare. And a previous talk last week mentioned this, and we say this all the time: zip code influences genetic code more than genetic code influences zip code. And so if these are true, then we're going to take a look at some of these factors. Now we're going to switch right here, and we're going to switch to the GIS point of this. Now we're going to be showing you data that any healthcare facility routinely collects. And so what we say is this: patients have addresses. Addresses have geographic coordinates. Therefore, patients have geographic coordinates. Well, patients have diseases and they have symptoms. Therefore, symptoms have geographic coordinates. And so what we're going to do is, when you take these kind of data, you're going to get what's called a point swarm. Now, the point swarm could be, like I said, any kind of data collected routinely in any healthcare facility. Now, these point swarms also have their own ability to form different density clusters. Now, you will see that these clusters are what we call hotspots. Now, the thing about hotspots you're going to see is that when you start changing the scale, now this is already programmed into it. As you start changing scale, your hotspot starts changing structure. And if we go a little bit further, you're going to see that these hotspots begin to resolve into typical little areas. Now, the thing about these data is not only can they be spatially stamped, they can be time stamped. So this is an aggregate over multiple years. Well, maybe it takes multiple years to get these hotspots. Remember, this is a hypertension hotspot. So if we take the year one of these data, we can take that and we can look at it, and you're going to see it's very similar to the composite. Year two data is also very specific to the hotspots, and you're going to see that year three again has about the same spatial configuration. And year four also has the same configuration. And now what we can do is we're going to take a look at both of these, and we're layered the 1 year data onto the composite data. And you're going to see that the hotspots really 1 year persists over multiple years. Now, if we take these data off, we're going to say, well, we were just talking about environment and factor could be related to different health conditions, and we're talking chronic diseases. So as a first analysis, what we did was we collected USDA food desert data. Now, the USDA food desert data, we downloaded. Now, that's based on census tracts. They use census tracts, and they use two thresholds. 20% of the population or more fits federal poverty status, and 33% of the population is more than a mile away from a grocery store. Now, what you see here is that when we have these type of information, you're going to notice that when you look at the hotspot information superimposed onto the food deserts, you're going to see that there's a cluster of food deserts, and you're going to focus right about here where these hotspots persist. And what we're going to do is now we're going to show you, and Craig's going to do this, we're going to let Craig dive deeper into the data that we have access to show you some of the issues. And I'm going to stop my screen sharing right here and let Craig take over from here.
All right, thank you, Russ. So we're going to switch gears here a little bit. So we are going to go from the ArcGIS Pro desktop application that Russ was just using to the ArcGIS Online platform. And so with this, I've done a 30-minute drive time analysis oriented around the AdventHealth Orlando Hospital campus. And so With this analysis, this can take traffic patterns into account. So if you wanted to look at, do an analysis on rush hour versus early morning traffic or early afternoon, this program and this tool allows you to do that. Next, I will throw on the USDA food deserts data that Russ had just previously presented on. You can see here we have the clustering of food deserts. And also, if you'll notice, the 30-minute drive time, there's quite a few food deserts right in here just within 30 minutes of this hospital. Next, I will throw on the hypertension hotspot data as well. And so again, you can see the densest area of this hotspot and the cluster of these particular food deserts, they overlay quite nicely. So we're going to switch over to business analyst. And with business analysts, we have access to terabytes of curated, publicly accessible data. This one data layer that I have on right here, this pink layer, is the federally defined census tract layer. And so I have that overlaid on top of the food desert data. And so we're going to focus on one food desert in particular and just kind of dive a little deeper into some of the data that is contained in this area. So here we have a number of tools. Whenever you click here, we have a pop-up. And so we can create comparisons between different areas, both local and national. We can generate reports that are compiled with income data, with ethnicity data, with health data. And we can also completely customize any of these. We can create infographics as well that are populated with the same sort of data. And so for the remainder of this presentation, we'll be focusing on the infographics tool in particular. So we customized this infographic just for this presentation and labeled it Community Snapshot. And so some of the data that you can see here, we have a median home value of this particular census tract of about 370,000. We have a median household income of about 24,000. We're going to dive a little further into this data to see where that discrepancy lies. You can see the total number of households, total population. We have an unemployment rate of about 19.7%. You can see the percentage of those uninsured in this census tract right here. And we have some poverty statistics and also at-risk population data here. You can see here about 50% of the households in this particular census tract are on food stamps or receiving SNAP benefits. About a quarter are households without vehicles, so they have no mode of transportation to get to and from hospitals or doctor's visits. And about a third of those are households where individuals have disabilities. So this infographic, we have a second page. It's a much more data-dense view where we can dive a little further into some of the data that we presented on that first page, or you can add additional data to kind of supplement that. And so next, we're going to change scale. So we're going to go from the census tract view up to what is known as the census block view. And so with that, we're going down in scale, and we're at the same time increasing the level of detail that we can see from this data. So again, this was the primary focus area that we just looked at as the census tract view. It was one solid polygon. It is now 3 separate polygons broken down into the block groups. And we're going to focus on these 2 block groups in particular that is divided by this major road. And so, once we jump into the infographics here, we're going to compare and contrast some of the data that we see from these block groups. So for the one on the right side of this major road, we have a median home value of 480,000. We have a median household income of 138,000. So you can see here right away, as compared to the census tract view, that this is much higher than whenever it was included in that total area. We have a 3.9% unemployment rate. You can see that the percentage of uninsured is much lower. And you can see the total numbers here contained within the poverty statistics and the at-risk population. Those numbers are also significantly lower than what was seen previously. And so now we're going to switch over to the left side of the road, and we're going to compare this data to what we just saw on the other infographic. So here we have a median home value of about 128,000. We have a median household income of only 18,000. So you can see right here where that discrepancy was for where the median home value was so high and the median household income was so low. We have an unemployment rate that has gone up to 25.1% on just the other side of this road. We have the percentage of uninsured that has gone up quite a bit as well. And as you can see here, the poverty statistics and the at-risk population statistics are also much higher than what we saw previously. And so, really, knowing your community can aid in planning targeted outreach efforts. Those outreach efforts could lead to uninsured cost mitigation from the hospital. You can work on targeted sponsored food drives or farmers markets that accept EBT. We're barely scratching the surface with the amount of data that we have access to and the types of analyses that we can do with that data. With that being said, we have access to an online repository of terabytes of additional data that we have access to and can use for analyses. Some of those being national healthcare spending data. We have national medical insurance coverage data. We have access to national diabetes medication users data. We'll change scale once again, and we'll go to a global scale. We have access to global air quality data. We can look at global human development index. We have access to data at the neighborhood level, and in some cases, the individual level, all the way up to global scale data. And so to discuss this idea just a little bit further, I will turn things back over to Russ.
Okay, thank you, Craig. And so what I would like to conclude with here is this. Now, what we can do is this. We were using already those defined boundaries, but you can create your own boundaries. So if you find your hotspot data, or whatever phenomenon you're interested in, you create your own boundaries. So that hotspot area that had those food deserts is about 130,000 people total living there, 44,500 households, about a $45,000 median income. And it's about 8% of the 19 to 65-year-olds have no insurance. Now, here's where I think that as a biologist, this is what kind of really scares me. So we say, what is our data? What is our responsibility? What do Craig and what do we do as researchers? Because you see, zip code influencing genetic code means a lot when we know about epigenetics. And we now know that where you are and what you do can affect you. You can have acquired traits. And therefore, your health effects could be because of what your grandmother ate or not ate. And there's a host of other factors. And we know that certain hotspots, especially chronic disease hotspots, can persist over time. So what do we do with that? Now, I'm going to expand a little bit further. So if you look at the top of this image, you're going to see that we have this thing right up here. And what is this right here? Well, this is tissue data. These are microscopy images that we have classified using our software. We look at the distribution of cells within tissues. We can use artificial intelligence to do that, which means that once you classify one type of images, we can classify ultrasound images, yours, and I heard electronic medical records. We can classify x-rays. We do that over time. We can couple that to your data. We can couple that to your envirome, to your blood type. Because you see in 2014, Eric Topol published a paper in Cell, Individualized Medicine Pre-Womb to Tomb, where he talks about the human GIS. We can layer hundreds and hundreds of layers. And I agree with Eric Topol that we want to be less paternal and give people more access to their own data. So we can scale from your cells and tissues over time to blood analyses, to where we even think that we could utilize this in real time, use your cell phone camera to take a picture of your throat, your mole, to send in AI coordinated. So we have access to be able to scale from within the cells all the way to the global scale. And our question is, what do we do with these kind of data? What is our responsibility? And we thank you very much for this presentation.
Thank you, guys.
Thank you. And I go right here. There we go.
Wow. Thank you so much for that. I think most of us in listening to your presentation probably will have some privacy issues or just questions about privacy. There was, Dr. Carr asked on the chat, are there built-in ethical parameters within the data systems and users so it does not encroach upon privacy? And if there are, who determines this?
Okay, so thank you for that question. This is a wonderful question. PHI and PII, right? So private health insurance and private individually recognizable information. So information. In this case, there is only one consideration. When we zoom down to these data, if you're looking at a very rare disease and we get to a census block level in a rural area, the argument is less than 20,000. So you have to be careful because you could identify somebody. Now, that is for us. We stay within the healthcare system and we follow the IRB standards with what practitioners would have. That is those data. We got rid of the data. The points were proxies. We utilize what you would do, Dr. Wee, as a practitioner, your same level of ethical concern that your patient is not revealed. So when we talk to them, it is housed within encrypted data, all that. And one of the beauties of it is that we get to present this stuff to you guys, bioethicists, because in a way, I see as always, the power of doing this. And then you're like, really, we got this privacy issue. And then I see the duality of it. And Dr. Carr was talking about this. We say, oh, we can't have these data. But you know how many businesses and how many people on Madison Avenue have access to my cell phone data right now in real time, which Craig and I can take. We can use geofencing data and go, well, we don't really know it's you. Yeah, we know it's you, because if you have social media open and you make a comment, you're going to get an advertisement.
Yeah.
So on the one hand, it is bizarre that they don't really have the same ethical standards. But as soon as we get into medicine, where we could access and provide, we could use ethical standards to go, if we know one area has these kind of characteristics, we can use models and find all the other areas and go, let's go out there and go to you people and say, you know what? Because guess what? You guys know that there's differential healthcare to socioeconomic and racial ethnicities. And we have a fear that, for example, breast cancers in certain classes are being diagnosed more prevalently at 3 and 4 stages than at 1 and 2. And you guys know that detection of cancers early on is far more correlated with success than later on. Well, what if that's differentially biased because of racial ethnicities and socioeconomic class? I don't think as a healthcare institution under Christian principles, that's acceptable. I'm not an ethicist, but that kind of bothers me. And we're talking now mothers, brothers, sisters, fathers, aunts, uncles, children. And I wonder about that. And that's why I think that, first of all, a consortium like this is where I think the discussions and the arguments, because I don't feel like I need to get my way. I need to understand how we can deal with this, because I do sit back and go, Butler, you studied this. Look at what you have access to. What are you going to do with it? And that's why I'm so pleased that we get to present to you. I don't know. It's not my responsibility, but I hope that we do have some responsibility to this, because we do know if it's the case. And I followed Jeffrey Brenner. That means, ladies and gentlemen, that we're talking like 10 to 20 to 30 million Americans driving healthcare costs. And if we're correct, and Dr. Carr, you mentioned this, and we talk about the business, it's within business interest to maintain a population so that we can generate dollars. And it's inadvertent, except maybe for profit healthcare. Oh, I just said that. But I'm telling you that does bother me a little bit if that really does happen. And so I wonder about that.
Wow. Yeah. I don't know about the rest of you. I am just feeling very sad that our time is up. I wish we could, again, have more time to discuss this. Thank you for all of you who have tuned in. I want to be mindful of your time and also say a brief word about November 19. We have 3 more fantastic presentations coming up on November 19. So please tune in, and thank you to all of our presenters today. Fantastic. We really appreciate your good work.
Thank you.
Have a good afternoon.
Thank you.
Thank you, guys. Very good presentations.